Thank you. And we go to the last presentation. Let me get it there now. Yeah, yes. You have to put it on the table so that people see it and don't go. Very important, eye, visual. Okay. So let's put the lights down again. And this is my top 10 coronary interventional trials of 2022. So you'll see maybe in this 100 slide presentation, maybe 5 slides of 2021, all with the 2022, with the clear, my tribute to where we are now, with the Andros Grinzik, with the father of angioplasty, with the dream of catheter-based percutaneous treatment in vascular disease in alert and awake patient, and which is my addition with the safety, appropriateness, and ambulatory, because majority of the patients go home same day nowadays after PCI. So basically, what I'm going to show, the trials of this year, which have made some impact in our clinical practice. So starting with transradial access versus transfemoral for PCI, the meta-analysis of the randomized clinical trial just presented in European Society of Cardiology. This is the old topic, but because it has gone to the guidelines, I wanted to remind once again to everyone that where we are, the transradial access versus transfemoral access published in Circulation, and you see the number of trials, 7 trials of 20,000 plus cases. Overall shows all-cause mortality, which is the radial in red, femoral in blue, 0.5% difference, with making a significant p-value. And more important is the benefit patients who are anemic, also you need to do more radial volume. And they define more radial volume means your lab is doing 70% intervention as a radial. We are intermediate, at present we are about 50. So it's the 30, 70 and above. So we are in the intermediate group. At Mount Sinai, we used to be by 2030 about 5 years ago. So clearly it has been catching up. Then the major bleeding, basic benefit, one is the mortality. But how the mortality benefit is coming? Is largely because of the bleeding. And this is what the bleeding was the whole talk today about this antiplatelet therapy of Dr. Mehran very elegantly put together. Of course, some of them are clear message, some are not that clear message as we had in the discussion. But the bleeding is the key. Every trial showed lower bleeding with the transradial versus transfemoral, and particularly if you are using additional agent. Clopidogrel, new P2Y12 inhibitor. So, and you have radial intervention, you have further benefit of lower bleeding. So these are the all individual outcomes. As you can see, the orange is the radial and the blue is the femoral, all of them favoring except the crossover. You decide radial, even in the great radial centers, about 6% will cross over to the femoral. So this is a direct effect versus is mediated through major bleeding, it remains part of discussion. So what has happened now with our guidelines, that it's a class 1 indication of in patients with acute coronary syndrome undergoing PCI, a radial approach is indicated in preference to a femoral approach to reduce the risk of death, vascular complication of bleeding. Now, in patients with stable disease undergoing PCI, the radial approach is recommended to reduce excess site bleeding and vascular complication. The major benefit is patient with acute coronary syndrome with a lower mortality. So key overall in the country now, in United States, about 38%. Going up, as I said, Sinai, we are about like 52%, but many countries, the radial interventions are over 90%. India is one of them. There's 94% interventions are done by radial procedures. Second is the definition 2 trial. What is that? If you had complex blockage, should you put 2 stents versus 1 stent? We have many randomized trial. They have these investigator of the definition 2 trial try to come up with some criteria based on the lesion, major or minor criteria. So if you have minor criteria, 1 major, 2 minor criteria, that should you use 1 stent versus 2 stents? This actually has been the big, I would say, the debate. Some trials have shown benefit, some don't. And this is actually the idea was your complex case, you do 2 stent or do a provisional group means only 1 stent, and you put a stent in the side branch only if necessary. And what it showed, the benefit height of the blue bar versus the provisional being in the orange, lower at 1 year, and this is the 3-year data presented this year, the significant 2 stent approach. So once you have a complex blockage. Based on their criteria, that two stents are better than single stent. And what the problem is, when you try one stent, about anywhere from 18 to 30%, actually one of the trial, DK Crush, 46%, requires second stent. And what we have learned is, when you put a second stent, your event rate in a one stent group almost triples. So therefore, better you plan. In complex case, going with the two stent strategy, which is better overall. This is the same way in the DK Crush trial, the simple versus complex. Complex case is the one where the two stent approach, which is the DK Crush 2 versus single. In this single, 46% got the second bailout stent, and clearly, as you can see, outcomes were better with the two stent approach. Then drug-coated balloon. I would say that's something which we always miss. Has not come to the America. Some trials are just starting. Drug-coated balloon is available for the peripheral interventions, but for the coronary, while it's available outside United States for almost 6-7 years, it's supposed to come very early, but you remember 4-5 years ago, for the peripheral, lot of data that higher mortality in the endovascular drug-coated balloon. So FDA, it put a really dampened the enthusiasm of the drug-coated balloon into the coronaries, and still trials are ongoing at present. Now 3 companies have just started. We'll be one of the center for one of the trial for using the drug-coated balloon for the coronary intervention. So what is the drug-coated balloon? Compared to the drug-coated stent, where the drug is on there, here is the balloon. The drug is on the balloon in a very it stick to it, and once you inflate, it goes into the vessel wall. And this has been done by many trials, and one of them, what has changed or the practice in particularly Europe and other places, in a small coronary artery. Because small coronary artery, we define less than 2.5 millimeter, which makes about 30% of our coronary intervention. The DES can be used, but question is, can you do better, particularly the long lesions where the restenosis rate may be 20%, 30%. So can you do it without putting a stent in those cases? And this is basically was the basket small 2, the primary overall trial data that comparable DES versus drug-coated balloon. This is all cases. And anytime if you have a drug-coated balloon and you have to put a DES, your event rate goes tremendously up. So within this subgroup, as you see in the diabetic, and that's where the data are, that patients without diabetes and patients with diabetes, the diabetic. So as you can see here, the without diabetes, this is our drug-coated balloon, this is the DES, but in diabetic patient, there was a lower TVR. And that is what the biggest concern. Event rate in diabetic is higher compared to non-diabetic, but in the diabetic patient, TVR was almost 40% lower using a drug-coated balloon compared to drug-eluting stent. And this is the same data follow-up here. So key is, it's not uncommon, actually at present, and then for patient with whether it's stable CAD or acute coronary syndrome, benefit is there. And this is where our mindset now is practice when cases are being done. When there's a small vessel, you prepare the lesion by your techniques of the balloon, rotational atherectomy, whichever need to be done. And if you have a good, successful result with doing FFR, or if you have no dissection, drug-coated balloon, and just leave it there. No drug-eluting stent. But if you are unsuccessful or suboptimal results, then drug-eluting stent is better, particularly for the larger vessel. So a small vessel, basically, the drug-coated balloon is taking the major play. So then imaging trial. Imaging basically trial to improve our overall outcome. This is the angiogram. This is the IVUS. This is OCT. This is our NEARS, which looks at the plaque. And then we have FFR and IFR, physiological testing, which was shown earlier. So all these trials have made us more, I would say, precise in terms of, one, who should get the intervention? Secondly, how can we optimize our results of intervention to have a better outcome? And this is the two of the trials using IVUS XPL after the Zions stent and ultimate trial with a 3-year data showing basically that lower mortality in the IVUS guided group compared to, this is a randomized trial of 1,300 patients combining two trials that almost became half. with terms of better mortality with the IVUS guided. So really, and of course, rest of the outcomes are better. So key seems to be that once you do imaging guided PCI, it's better compared to otherwise that just do a based on the angiogram. The second question was that you have a intermediate lesion, anywhere from 40 to 70%. Should you use based on the IVUS intervention, or you do IVUS, the intervention based on the FFR? So this was the flavor trial. You can see here what they did basically, that if FFR was less than 0.8, they got the stent. And in the IVUS group, if the MLA less than 3 or 3 to 4, but high plaque burden, got the stents. And then after that, try to optimize, get a better FFR, more dilatation, and of course, by the IVUS, you have a good stent expansion, having at least 5.5 millimeter. So you say, well, these both techniques have been good individual data we have. So, but what about in the randomized fashion? You do show the randomized fashion. This actually has been shown now. It's just published in NEJM about last month. So presented in ACC earlier this year. Just came out NEJM. I have not updated the publication, but just showed that using both, you're good. You decide IVUS based or FFR based, outcomes were identical at 2 years, and these are the individual and outcome, including the your quality of life SAQ measures in both. So clearly, whichever way you want to do, one, imaging does better, imaging or whether physiological or anatomical, improve your outcome long term with the PCI. Second, whether you go with the FFR guided or IVUS guided, this is large trial published in NEJM, the outcomes were identical. Then question comes, what about OCT and FFR? We know that as Dr. Narula presented, FFR more than 0.8, you can leave it alone. Less than 0.8, you do intervention. Even in less than 0.8, not everybody gets the event. There are various criteria, plaque remodeling and showed. But question always comes, even patients with FFR of more than 0.8, recommendations are, do not do PCI. But then some patients come back. We're actually presenting a case in our CATH conference next week. Patient at FFR, done 3 months ago, negative 0.89. Patient came back within 3 months with an anterior wall MI. It was LAD. FFR was documented negative 50-60% lesion. So question is, can you be more precise? And this is a trial called combined OCT FFR. What they did is, patients who have FFR of more than 0.8, you should not do any intervention on them, right? The group, if you can do the OCT, and OCT, look at the cap thickness. If your thin cap fibroatheroma, negative or positive. So this is about, the ratio was about the 1/3 had the positive thin cap. And basically what happened in the thin cap people, there is a 5-fold higher event rate. 3% versus 13%, 4 to 5-fold higher. So now, should you do the stent in these groups? That is the next step. That will be the combined OCT FFR2. So first you have to identify the group, then you say, well, by doing the intervention, will it make a difference? So we are not there yet, but we know that we can identify that many times even in the FFR negative patients who get the event rate. And these are the individual endpoints shown here. Both are FFR negative. One is the tick for positive, tick for negative. Height of the red bar, which is the tick for positive, has a higher event rate as shown here. There are 3 trials will answer in next 2 years the imaging. One is the defined GPS. This is the patient patients after PCI getting IFR, and then you optimize the result of IFR compared to your standard of care. Second group is based on the OCT guided PCI versus angio guided PCI, Illumin 4 being done. Ziad Ali, our earlier fellow who has done a tremendous work in the OCT, is the PI of this trial. And the lastly is the optimal randomized trial for the IVUS guided PCI for left main. These are the 3 trials. One will become positive, the imaging will become class 1 indication in our armamentarium. Now, we are also going further now. One is, we know the epicardial. We take care of the epicardial, we understood IFR, FFR all. But what about the microcirculation? Which we know that many times patients have symptomatic or patients have bad outcome even with the no significant epicardial disease. So So now coronary flow reserve, which takes care of the FFR, epicardial vessel, as well as microcirculatory resistance or coronary microcirculation, has come into retrial. Retrial in the sense that we were doing that back in the 90s, 96, 98, then 2000, then turns out to be CFR was no good. Now there is a total resurgence. Second is spasm, vasospastic angina, and using the acetylcholine. And to really see the infusion to diagnose the microvascular spasm. So those are the few trials. One of them is combined assessment of FFR and CFR for decision making on coronary revascularization, which is the Ilias registry. And it showed that if you both are normal or both are abnormal, we understand that. More important, what we need to know that if one is abnormal or normal, CFR or FFR is anything better. It looks like they're all in the middle. These are the individual outcomes, as you can see here. So basically, the discordant are in the middle. Second, combined pressure and flow measurement to guide treatment, defined flow study. And they also have same FFR, CFR, just to give the number, when FFR more than 0.8 is normal, CFR more than 2 is normal. And this we can assess now in the cath lab. You don't need to go to MRI or CT scan or somewhere to measure the coronary blood flow. We do it in the cath lab. We have a very nice equipment to measure this in the cath lab, which is being done. And one of my associates, Sweeney, is taking this project to the next level, really assessment of the microcirculation, and which can easily be done in the cath lab. So question is same. There will be some cordant and discordant, and answer there is again about the same. That if you are both abnormal, you bad outcome. The question is if you're one of them abnormal, you're still in between. So basically message came editorial of these trials was that CFR at present does not add any additional value over FFR. So yes, probably it is okay to do it in patients who have no non-obstructive CAD. For the microvascular assessment and maybe more aggressive, there is a tailored approach for the microvasculature. But once you're deciding from the coronary obstructive point of view, it have a very little value at this time. Then we always say, patient who had a stent, we do a stress testing every year, sometimes every 6 months. There's no clear-cut guideline, and this is basically routine functional testing or standard of care in high-risk patient. The guidelines just show that patient with a high risk, 6 months after revascularization, routine imaging-based stress testing at 1 year after PCI, and more than 5 years after CABG, class 2B recommendation. We always do it. I'm sure many of you in the audience here do stress tests 9 months to 1 year because patient wants to know that you did good, I'm fine. Am I out of the window? Basically that there will be no worry about restenosis. We always do stress test, let's do the stress test. So this actually major trial to answer this question, and they took the high-risk patients. And high-risk patients were based on the disease, left main, multivessel, CTO, and long lesion length, or high-risk clinical group. Diabetes, renal failure, particularly diabetes, right? We say patient may be asymptomatic. You may develop restenosis, renal failure, a patient have acute coronary syndrome. So high-risk patients. So once they have a successful PCI, they did 1,700 patients, half got the functional testing group every year for 2 years, and the other one routinely. And guess what? Primary composite endpoint, death, MI, unstable angina, no difference. So basically, the actually editorial by one of our colleagues from Mount Sinai Morningside, Jacqueline Tamis, wrote down that maybe routine stress testing is a class 3. It may not harm, but there is no need. But you got exact outcome. I don't fully agree with that. I think we need to learn a little more. Maybe the benefit will start happening after 3, 4, 5 years, maybe not at 2 years. Okay. Lot have been spoken about depth de-escalation. Telos AMI, the latest one, and this was a good question, as we all know. Early time, we worry about thrombosis. Later time, we worry about the bleeding. So question was that patient with acute coronary syndrome, MI, you give aspirin ticagrelor for 1 month, and after that, you de-escalate to clopidogrel versus ticagrelor. This has been shown earlier, but overall message is very clear. De-escalation, lower bleeding, And more importantly, nothing in terms of your ischemic endpoints. So you don't pay the penalty. Higher ischemia, remain lower, and of course you have almost a 50% reduction in the bleeding. This is all in addition to all the trials which have been discussed earlier. So clearly de-escalation, yes. Then question comes abbreviation, and again has been covered by Dr. Mehran very well with the master DAPT, stop DAPT to ACS, but there is some message came up. So this was the master DAPT trial that you give for 1 month versus 6+ months, and overall showed these are all patients with high bleeding risk, and overall outcome significantly lower bleeding, 1/3, and no penalty of higher ischemic endpoint by decreasing it, as you can see here. So major bleeding significantly decreased, other endpoints were identical, and actually also lower stroke rate with the abbreviated DAPT. Now, then additional data were presented about patients with the MI patients also were the same, and patients with a complex disease also identical outcome. So these are the update of the master DAPT, basically showing that patient with high bleeding risk, it's okay to stop at 1 month, but only high bleeding risk patients. But now question comes, what about acute coronary syndrome? Can we decrease for 1 month in ACS? Remember, at present guidelines are ACS DAPT for 1 year. A stable patient, 6 months. So this is what they did is stop DAPT. 2 trials were done, stop DAPT 2, and then they did a ACS trial, stop DAPT to ACS. So from this group, ACS patient they took to make it a large number, 4,000 plus 1 month of DAPT versus 12 months of DAPT. You say, well, things looking good all the time. Every trial has shown, cut it down. 1 month is good enough. The question is it good enough in acute coronary syndrome also? Well, we have the answer. As you can see here, no good. You cut down in 1 month, your MI rate is higher. Yes, you do have a little lower bleeding, but this is concerning. Just about double your MI rate. So say, well, maybe it's only 1 trial which showed this higher bleeding rate. So, well, let's go to some. There was another trial done from Korea, 1 month DAPT. They took again all comers, 1 month DAPT, 3,000 patient trial versus 12 months. And guess what? Overall looks good. Overall outcomes identical, but there also in acute coronary syndrome, you can see here curves on this side, 7.2 in the 1 month DAPT versus 5.1. What is the conclusion? That in acute coronary syndrome, you cannot reduce the DAPT to 1 month. You can de-escalate. There are data on the ticagrelor or prasugrel. You can de-escalate, but or from 10 can become 5, but you cannot reduce the DAPT, and that will give you have to pay for the ischemic penalty. Then left main. Left main, of course, everybody is aware of this, our Excel trial, which is 5-year. Mortality was 13% in the PCI group, 9.9% in the CABG group, significant p-value, although overall outcome at 5 years were not significant. 22% in the PCI, 19% in the CABG group. These are the patients with moderately complex left main, randomized to Zions stent versus CABG, and these were the data of death, stroke, RMI at 5 years. So now, since then, we have some more data. So major paper by Brownwald group of the 4 randomized trial of the Syntax, pre-combat, Noble, and Excel. 4,400 patient, median Syntax score 25, and have a follow-up up to 5 to 10 years. And guess what happened? So basically what we found that by doing a PCI, you have a 0.2%, 0.2% higher mortality per year. So in 5 years, you have 1% higher mortality compared to CABG. You go to 10 years, you have 2% higher mortality than CABG. Again, non-significant. Other endpoints, basically the coronary revascularization and MI are higher, slightly trend towards lower stroke rate with the PCI. So conclusion basically is that not from the mortality point of view. If patient has a good, the overall patient is a more complex disease, probably will do better. And these are the individual endpoints. More important, if you have more complex disease, Syntax score 33, left main with 3 vessel, CABG is clearly better than PCI. Others do very well with the PCI, and that is what our pattern is. Question always have come also that if you do a PCI of the left main, particularly majority of them, 75+% are the distal left main bifurcation. What technique should be used? Original data DK crush showed that 2 stent of the DK crush was better than the provisional. Now this EBC main trial basically showed, although they did not test the DK crush much, but more so for the culotte, systemic dual stenting versus provisional stepwise. In this case, about as you can see here, about 11-12% requires second stenting, and basically showed that overall similar outcome. So when doesn't have to be DK crush. The 2 stent approach, although in this stepwise provisional, was slightly better. But overall, key, we do mini crush. So key is complex lesion, left main or non-left main, 2 stents are better. Now this is the little FFR trial field, little confusing. And I hope I show all these 3 trials may make my point. FAME3, floor MI, and the FRAME AMI, 3 trials. One was the FAME3 trial, basically was the trial of complex CAD but not left main, randomized to FFR guided PCI or cabbage. So anybody FFR less than 0.8 had a PCI or cabbage based on the angiogram. Cabbage was done based on the angiogram, and basically what did it show, the trial? That PCI was inferior. 10.6% event rate of death, MI, stroke, or repeat revascularization in 1 year compared to 6.9 in the cabbage group. This is similar to syntax. Syntax the same. At 1 year, we lost to the cabbage. So question, we thought maybe by doing FFR will become a little better, smarter. It turns out to be not the answer. And why it was not the answer? This is overall individual endpoints are shown here. Clearly, the cabbage was superior to the PCI, which is the height of the red bar, that lower event rate. But key is the complexity. So what we learn is that even if you make a decision based on FFR, it has to be the complexity of the CAD has to come into the equation. If you have lower syntax score, you see this here, the cabbage has higher problem than event rate than PCI. But once you start getting to the more complex, the cabbage has a lower event rate compared to PCI. So FFR guided, but at the same time incorporate the syntax score in these cases. Now, one good thing happened that by doing the PCI, that return to work, young people, better quality of life measures, but they are softer endpoint. But the major endpoint, there some more data will come that really which group of patient we had a higher event rate at 1 year in those FFR group and so on. Now, yeah, so about 33% were diabetic. So maybe in the 33% diabetic subgroup, the analysis will be coming that maybe those group had a higher event rate, we don't know yet. But various subgroup analysis will come. But it was across the board. In overall, the event rate was diabetic, non-diabetic were all, we lost to the cabbage. Question is, diabetic FFR event rate, in diabetic and non-diabetic, was the FFR event rate different? That part we do not know. The second point was, you have multi-vessel disease patient STEMI. Your RCA total 90% LAD. Should you do the stent of the second branch? Of course, you have to open the main vessel, which is the culprit. But then the second vessel, you do angio guided or you do FFR guided, of course. So this, most of the time, complete trial, complete STEMI trial showed that you have non-culprit vessel revascularization, you do based on the angiogram. They did imaging or FFR in less than 2-3% of cases. That I presented one of my top 2 years ago. That was complete trial, complete MI trial, that second vessel or non-culprit vessel you based on the angiogram. But then everybody wants to go take the field to be a more precise way. That maybe you should decide based on the FFR. That FFR positive, less than 0.8, only you do PCI. And if more than 0.8, you leave it. And compared to angio guided, that any lesion more than 50% you stent it. So this was the flower MI trial and in STEMI patients. Just remember this one. STEMI patients, more than 50% stenosis of the non-culprit vessel, and basically showed that overall and FFR guided PCI was 1% lower event rate. Higher event rate compared to angio guided PCI, but more importantly, as you can see here, there was no true advantage of the FFR guided PCI. In height of the red bar is almost higher in every subgroup of the MI urgent revascularization, although p-value was not significant, but there were other points. So if you defer it, look at the revascularization. FFR guided PCI 6.5, angio guided 4.5. That means 2% of patients in 1 year came back for revascularization and higher hospitalization in the FFR guided group. So you can say that it's not only that it was neutral, it was maybe a little it was negative that there was higher revascularization in the FFR group and more patients were rehospitalized. So overall, there was no benefit. Rest of the parameters are shown there. So this is one. I told you about FFR. Now get ready for another. We think that we understood everything, but then there will be a trial come which will kind of mess up our mind. Frame AMI trial. There's another group of investigator, FFR guided complete revascularization versus angio guided. Only thing is, in this case, they took all the patients' MI, STEMI as well as non-STEMI. So it was not STEMI. Flower MI was only STEMI. This you use STEMI as well as non-STEMI. Culprit vessel, non-culprit vessel. When they FFR guided, decided in the non-culprit, basically, if you're less than 0.8 PCI, more than 0.8, you defer. Okay. You say, well, maybe it should be the results just like the previous one. Look at that one. Now, FFR guided PCI has become superior, 7.4 event rate versus 19.7. Look at the height of the disparate graphs. Angio guided red and FFR guided blue. I can just say that I've been studying this field, doing it personally. This kind of difference of fourfold lower all-cause death MI has never seen in any trial, ever. Whether you really trust this, but these are the data. But just to say, such a dramatic benefit has never been seen in any of the FFR, IFR trials. But this is where we are. So key is that a little confusing field, but you can just say maybe it's just because 1/3 of the patients were non-STEMI in the frame trial. Now, the last, I would say the trial of 2022, which again, I had to present it with a little my sad face. This is the revived BCS2 trial. That is PCI in LV dysfunction. So question was that, remember Stitch trial, patient with LV dysfunction, they were medical therapy versus cabbage. And they basically found that after 5 years, cabbage started getting superior. Early part of the trial, until you see it like first year, or 2 year, no benefit, then started showing curve in favor of the cabbage. In these, of course, after 10 years, became statistically significant. Took long term. So then investigator decided that let's do a PCI in these cases. And let's be very precise. Not every case of the LV dysfunction, you want to do PCI. So what they did basically, patient with the EF of less than 35, complex CAD, not simple 2-3 lesions. They have separate, they don't have a separate, not a syntax score. This is the BCI score, more than 6, which makes it very complex. And then do a viability study. If the myocardium is viable, testings for either CMR, DSE, SPECT, or PET. And you can do PCI safely, at least in the 4 dysfunctional area, those are viable, should do better, right? I mean, patients, these other compared to medical therapy. Just like an OAT trial, PCI versus optimal medical therapy, and they've, of course, echocardiogram and everything done for the 24 months. This is about a 3.5+ year trial, 41 months follow-up, and guess what? No Very disappointing. No difference in death or hospitalization for heart failure. You say, okay, you know what? It probably goes, that's okay. But at least PCI will improve the ejection fraction. This is all, as you can see here, definitely unplanned revascularization was much higher in the medical therapy group, which expected, because they will become unstable and came back for the PCI. And the PCI did have the lower spontaneous MI, which has been shown by our ischemia trials and so also, that definitely, but then higher procedural MI, but spontaneous MI was lower in the PCI group compared to medical therapy group. Then you say, well, at least EF will improve. Guess what? These are the overall ejection fraction, was actually 27 was the site reported. This was the core lab about 34, or no difference in EF. Despite PCI of the minimum 4 area of ischemic viable myocardium. Now, only thing is, yes, you do better in terms of quality of parameters, KCCQ, overall summary, although at 2-year, benefit decreased. So part of the benefit decrease also, remember in the medical therapy group, 10-11% of patients got the PCI later, but those are all in this group. So some of the benefit is muddied because they got the PCI. Say maybe if you take those patients out, maybe EF will be different. But those are a lot of maybes. But overall, it's very disappointing that PCI didn't came to the, those who are believer in it. I'm a strong believer of the PCI. That's what we do and believe in it. But this is what the trial showed, no benefit. Now, what about maybe the diabetic patients? Coming back to the question earlier, your diabetes doesn't matter. EF very low or slightly low is still no benefit. Maybe the EF was less than very low, slight trend this way. Then age-wise, no. Heart failure class. As you see there, majority of these patients were in NYHA class 1 or 2, and only a small number was in 3 and 4. But again, no benefit. Now, you say, well, maybe complex disease, still no benefit. Any group you take did not have any benefit of the PCI. So these are the top 10 advances of interventional cardiology. Now let me put it together as a central illustration, the take-home message, what we learned from 2022, changing our practice. First, PCI and LV dysfunction ischemia, ischemic myocardium, no good. Second, FFR-guided PCI versus CABG, FFR-guided PCI in STEMI, and short depth in acute coronary syndrome, no good, should not be practiced. Then PCI versus CABG in unprotected left main, drug-coated balloon in small vessels, 2 stents in complex lesions is thumbs up, good practice. Imaging-guided PCI and FFR-guided PCI in MI, including STEMI and non-STEMI, thumbs up, 2 thumbs up. And the real is transradial PCI, short depth in high bleeding risk, and depth de-escalation, 3 thumbs up, because it has shown significant benefit of all these studies to make us better interventionalists and, of course, improve the patient survival. So this is actually the field. Interventional people talk about maybe numbers going down. It's actually slightly state also. Some interventional numbers are going up at present, but most important growth has been on the structural side, because structural field is really, because more and more we are truly offering to the patients. It's not that you're taking away from surgical. Majority of the growth, as Dr. Keeney pointed out on that graph. So growth happened a little bit of decreasing the surgery, but major growth happened in the procedure that you are offering. These high, I would say, the complex procedure becoming simpler to the patients to improve their overall outcome. And with that note, I'm going to stop here and take any questions. Any questions? I know we don't have the phone, but if the... Huh? Oh, yeah, good. How we do? Yes.
Dr. Narula said, I just want to clarify, if there is positive FFR in a symptomatic patient, not ACS, and has high necrotic core and hip fire is high and remodeling, you should first treat the lipid necrotic core aggressively, then try the intervention, or
no, so yeah, so very good point. I think those, once you have FFR positive, so those patients, we did the trial called FAME-2. FAME-2 trial was patients with coronary artery disease, little symptoms, more symptoms, positive stress test, negative stress test, then did FFR, more than 0.8, left for medical therapy. Less than 0.8, we say, well, half of them we do PCI, other half we say aggressive medical therapy. And guess what happened? The trial had to be stopped after 6 months. Why? Because in the medical therapy group, the event rate of acute coronary syndrome and urgent revascularization was 12% at 6 months versus 3% in the PCI group. So clearly that once you have FFR positive, your ball game is over. Now question comes, is your FFR negative? And you have those high characteristic plaque, that is plaque remodeling, all the high-risk features of the plaque. So there, the whole issue comes down that we know the event rate is higher in those cases. But question is, should you intervene besides just the medical therapy? There are just some data which we have from the Prospect to Absorb trial. A small number of patients, they have those kind of FFR negative, but then has a plaque characteristics of the TICFA more than 70% plaque. And then in those cases, in a trial, they put half of them, although 90% study, half they got absorbed stent, half medical, and their event rate was 13 versus 4%. So 3 times higher if you left them alone versus you put the absorbed stent. Absorb was the stent which had been out of the market because that created more trouble of stent thrombosis at 3-4 years, not available. So idea seems to be, yes, the high plaque features, despite your negative FFR, should benefit by intervention, because intervention becomes so simple. Complication of, if you say your high-risk feature plaque, 1 year event rate is 5%, we know that you put a stent, event rate may be 2% or 3%. So definitely will be lower. But those trials still have not, even same thing, the combined OCT FFR. So we know identification, but that is going on beyond medical therapy. Yes, the aggressive, what basically the message was that you need to treat them aggressively with the medical therapy. And of course, there's no data to say that you can do the stent on those cases.
Also, when we have a patient who has LV dysfunction and we're trying to, especially if it is new, and we just find it, and we want to always try to rule out ischemia by the myocardium. But the data here shows in these people, whether you did PCI or CABG made no difference, and that therapy was. Yeah. So what's the?
Well, I can tell you that I'm totally dumbfounded by the interpretation results of the trial. So that is what we taught everybody. Your LV dysfunction, your ischemia, PCI will do better. But right now, from one trial, I cannot say the data. Now, also, many of these patients went for surgery. So we'll never know that whether surgical benefit was there or not. So these were the less complex cases, but yes, it's still complex, but less complex cases who had a PCI, but they have all the substrate, which we have until now teaching everyone, where the PCI or revascularization should make a difference. But to our disappointment, for one trial, that did not make a difference. Whether there will be some subgroup analysis, because this was just presented in European Society recently, so this is a very hot topic at this time, that how it is going to translate into our regular life, how guidelines will change. So until now, the ACC our ACCHA guidelines of January had incorporated ejection fraction of less than 35% for revascularization. Even PCI and CABG, less than 35. Of course, CABG used to be always class 1. Now they have put both, 2A, PCI as well as CABG in multivessel disease and left main with a less complexity. But now, based on this data, how all these things happen, there's time to be seen. But yes, it's definitely the trial essence. If you go with the trial, this trial showed that even in patients with LV dysfunction and ischemia, PCI did not show much benefit, despite there were not complications. You say, well, maybe these were not the good operators. They had a lot of complications of PCI, very low. The elite group of interventionalists from the UK and this, that very low procedural complication, yet it did not translate into a benefit.
They showed that CABG also didn't make difference.
No, not in this group. This was only PCI. The CABG versus medical therapy was the trial called STITCH. That was a trial done 10 years ago. That also in the beginning did not show difference until 5 years. So then question comes, what if the revive to BCS starts showing difference after 6-7 years, just like the STITCH trial? So that part we do not know. Maybe we'll see a little curve separation, but at almost not 4 years, like 41 months, just about 3.5 years, exactly identical. So in the STITCH trial also, but STITCH trial has started showing some separation after 2 years. Then became significant at 5 years, more significant at 10 years in favor of CABG. In the PCI, at 31 months, which is 3.5 years, those curves are identical. Whether it will show any difference at 5 years or on, we do not know. Yes?
Weren't we classically taught that you have to have a lesion greater than 70%? Why do some of the trials say 50%?
Yeah, very good point. So question basically was, we call intermediate coronary stenosis. So what happened is, there are many data to show that even patients with the 40% and so do have a coronary event. So no disease, which is less than 30% and so, 40 to 70, 70 to 80. So there is a gradient. So once you get even intermediate risk group, you have a event rate. So let's say 30% blockage. You take a follow-up, then 1 year, their event rate will be 2%. You take, becomes 50, 60%, event rate becomes 7%. You become 80%, event rate becomes 12%. So this intermediate group, the question is, can you identify what are the features in that intermediate risk group where you can identify who will have a trouble? So there are a lot of things, measuring rubidium, the hot plaque, which eluded. Same, the positive remodeling, high-risk feature of the plaque, necrotic core, FFR positive. So all these features are identifying those cases in the intermediate group. We know that 80-90% will have event rate. But question is, in the intermediate group, can you identify patients who are going to have a higher event rate? So then, that was one point. Then you have to show, by doing the intervention, you will improve their outcome. And that was the FAME2 trial showed, that just in those cases you leave on medical therapy, event rate is 12%. You do the PCI, event rate goes down to 3%. So that's why this intermediate risk group comes in, that to be more precise, kind of better in terms of predicting the event on those patients.
So what do you do here when you have somebody with a 50% lesion, they have stable angina, they came in because they failed the stress test, or I'm just feeling bad, I don't want to take all these medication, you cap them. You see he's got a 50% lesion in the LAD, what do you do?
That patient will get FFR at majority of the centers in America, including at Mount Sinai. And if FFR is more than 0.8, we'll just maybe add a little more medicine and you discharge them. Now,
you wouldn't do OCT on them.
Yeah, so key is that OCT, just we are getting some data of the OCT now, but that is not the routine practice. Routine practice is just FFR negative and you discharge. Now, many of them will change further. So maybe if the patient comes back now again and you say, you know what, it's 50, 60, your FFR is 0.8. And even just to say that we say FFR 0.8, you leave for medical therapy. In that group, event rate is not 0, it's still 5, 6%, 4%. So question is, if your stent can make the event rate of 1 or 2%, why not? So what we do routinely, and this is what happens, question come every day. So we will not do it because it's a class 3 to a PCI that time. Now you put patient on medical therapy. And then if patient still continues to be refractory, then you can bring back the patient even with a negative FFR, knowing that the negative FFR does not give you immunity, that there will be no event rate. So that person that you have failed medical therapy, patient the typical ischemia, life-limiting ischemia, they can do their regular activity, will be appropriate by the guidelines to do PCI at the time 2, as a second or third episode after you try the medical therapy. Okay, with that note, we are ready for